I'd first like to give my personal thanks to you for coming out. You and I have talked a long time about this. We bonded long ago over a shared interest in all of these issues. So I'm grateful to have you as an ally, as a friend, as a colleague, and grateful that you agreed to speak to us today. We have one of our cardiology fellows who's going to give the introduction for you, and then you can get started. But thank you again for coming, and I look forward to many more years of fruitful collaboration. Dr. Brownell, you want to take it away?
Sure. So it is my honor to introduce Dr. Quinn Capers IV for Grand Rounds today. Dr. Capers is the Rody P. Cox Professor of Internal Medicine and the inaugural Vice Chair of Diversity, Equity, and Inclusion at UT Southwestern Medical Center in Dallas, as well as the Associate Dean of Faculty Diversity at UT Southwestern School of Medicine. Dr. Capers' clinical and academic interests include interventional cardiology, medical education, and racial and ethnic healthcare disparities. A nationally recognized leader of diversity and inclusion in academic medicine, Dr. Capers has delivered more than 200 lectures and trainings nationwide on implicit bias in medical care and has worked tirelessly to battle racism, prejudice, and injustice in medicine and cardiology. He was recruited to be an inaugural member of both the ACC's Diversity Task Force and the Diversity Committee of SCAI, and was appointed the chair of the ACC Diversity and Inclusion Committee in 2020. Most recently, he was awarded the Pamela S. Douglas Distinguished Award for Leadership in Diversity and Inclusion at ACC 2021. Beyond his leadership in diversity enhancement, Dr. Capers is also a nationally recognized educator and clinician. He was awarded, his physician peers have named him one of America's best doctors annually from 2009 through 2020. He was awarded the AHA Linneck Clinician Educator Award in 2019 and given the Professor of the Year Award in 2019 by the graduating class of The Ohio State University's College of Medicine. Thank you, Dr. Capers, for sharing the time today with us. Please help me in welcoming Dr. Capers.
Are you ready?
Oh, there we go. You would think I've learned how to do that by now. So hopefully you can hear me now. Thank you so very much, Dr. Brownell, for that wonderful introduction. Thank you to my good friend, Dr. Carol Watson. And thank you to anyone who had anything to do with me being invited to share some thoughts with you today. I'm really pleased to be able to do so. These are difficult times. It's been difficult times for a long time. And I will say this, I was asked to kind of give a personal, some personal insight to me, just kind of a fun fact. But if you don't mind, I'd like to save that for the end, for the Q&A session. And I'm going to go through, I do have slides here. I'm going to go through them quickly because the most fruitful part, I think, in this is not going to be what's on my slides, but it's going to be on some discussion that we can have afterwards. So with that, I'd like to start with this very important piece of art. It's very important to me for a couple of reasons. One is because my daughter, Christian, is the artist. But let me explain to you what you're looking at. You're looking at a physician, a Black physician, who's being crushed by two forces. On one side, a virus that is disproportionately killing people in his community. When he looks to his other side, he sees police brutality, the example given of racism. And he's being crushed by these two forces. Now, what's happening in the background? In the background, cities are on fire. Cities are burning with protests, with riots. And this is a picture of 2020. Now, I know you join me in disappointment that this wasn't left behind in 2020, but it continued on into 2021. But this physician, you see the look on his face is not one of resignation, it's one of determination that he will not be crushed by these forces and he's fighting back. This is what it felt like to be a physician in 2020 for your Black and Hispanic colleagues. And this is what it feels like now to be a Black physician. So when you see your fellow Black and Hispanic physicians, just know that this is what they feel like on the inside, as some of these atrocities that we see in the news continue today. As a result of really, mostly it was the brutal murder of George Floyd that we all watched. Academic medical centers came out and made bold statements, bold anti-racism statements of the variety of racism has no place here at this university. We will not tolerate that. And that's good. That's a good start. Those anti-racism statements. Your university, I'm sure, did the same thing. But I'd like to say that the most powerful and the most durable anti-racism statement that we can make is to diversify our ranks. That's the statement that has power. That's the statement that is going to lead to permanent change. And so I want this to be an evidence-based talk. So I'm going to give evidence to make a few contentions. We're going to give evidence to support that there is a lack of diversity in medicine. I expect of all the things that I'm going to share with you, that will be the least controversial point to make. I'm going to make the case that racism and racial bias play a role in that lack of diversity. I'll show you evidence that that lack of diversity harms our patients. And if I can show you that, then I ought to be able to show you the corollary that if we enhance diversity, that our patients will benefit. I'll show you evidence that barriers exist. We'll talk about what some of those barriers are to enhancing diversity. And finally, we'll try to end on a positive note and talk about strategies to enhance diversity that have been shown to work. So lack of diversity in medicine, again, that's not hard to prove. You're looking at here data from the Association of American Medical Colleges, a self-identified race of medical school matriculants from 1978 to 2014, almost a 40-year period. And what you see is that in that time, there have been, give or take 100 here or there, 16,000 medical students in this country. And so the group most represented by far is the golden line here, and those are self-identified whites. So they've gone from 14,000 of those 16,000 medical students to now about 11,000 of those 16,000. If you look down here, there's been only one group that has seen an increase in that time, and those are self-identified Asians. When you look at Blacks in red and Hispanics in blue, you see them intertwined, but no appreciable difference for an almost 40-year period. And then American Indians and Alaska Natives in gray, it's really hard to differentiate the gray line from zero. So this is a snapshot of almost 40 years of medical school matriculants in the United States. So again, not hard to convince you that we have a diversity problem. That does not mean, however, that racial bias plays a role in that lack of diversity. What is the evidence that it does? Well, here's one example. This is a letter from Emory University's admissions office, and it's an old one. It's from 1959. It's to an applicant. And it says to this applicant, "I'm sorry, I must write you that we're not authorized to consider for admission a member of the Negro race." Now, as you heard, I spent some of my time at Emory as a trainee, and I've got a lot of love in my heart for Emory. So I'm really not, it might seem like it, but I'm not criticizing Emory or throwing them under the bus for this, because it turns out that in 1959, there was a state law in Georgia that prohibited Emory or any other medical school in Georgia from admitting a member of the Negro race. Georgia, as I'm sure you can imagine, was not the only state that had this law. So prohibiting a person from an education simply because of their race, that's the definition of racism. If that's not racism, then we should stop using the word. So that is racism. Entire states had that law. And what that means, because even then, physicians worked 30 or 40 years before retiring, that means that the country was denied or robbed of generations of Black physicians. So that is racism playing a role in the lack of diversity in medicine. What about implicit racial bias? The bias that is unknown to us. We're unaware of it. It sits there in the back of our minds. And it is a product of the images that we've taken in our entire lives. Here's how it works. If every time I've seen a nun, that nun is shown to me as doing something warm-hearted and compassionate, After seeing that so many times, my brain will make that connection. My unconscious brain will say a nun equals kindness. If every time or often when I see a young Black male in a hoodie, he's shown to me as committing a violent crime, being taken away in handcuffs on the 6 o'clock news, playing the bad guy in the movie. After seeing that so many times, my unconscious brain makes that connection, that young Black man in a hoodie equals danger, equals violence. The power of implicit bias is that even though these associations are outside of our awareness, they can influence our behavior and have been shown to do just that. Such that if I'm a doctor and these two patients come to me complaining of pain, data has shown that for the woman who's a nun, it is likely that because of my positive association with her, that I leave no stone unturned to find out why she's in pain, and that I prescribe her the appropriate pain medicine. Young Black men in a hoodie, it is possible that because of my unconscious association, I really don't do much of a workup, and I don't give him the appropriate pain medication. But now that doctor, if you interview that doctor after those encounters, that doctor will say, I treat everybody fairly. It has nothing to do with bias. I'm using my clinical judgment. I'm using my clinical clues, but that doctor is not aware that their unconscious bias actually played a role in their decision-making. Now imagine it's not a doctor. Imagine it's a police officer who's called to the scene of a crime, and they arrive and they see a nun. If that police officer is me, it's possible that because of my unconscious association, I do everything I can to help that nun. And I approach her with kindness, with a smile on my face, and I'm talking to her in soft, quiet tones. It is also possible that if I arrive and there's a young Black man in a hoodie, that the first thing I do is take out my gun or take out my taser. And you don't need me to tell you how much this is playing out almost every week on the news. But yet, if you were to take that police officer who had those encounters and ask him if he treats everybody fairly, he'd say, yes, I treat everybody fairly. It has nothing to do with race. I use my judgment as a police officer. This is the role that implicit bias can play. Well, physicians are not immune. We have these implicit biases too. This study from Janice Sabin in 2009 showed when they tapped into the database where you go to take that computer-based test, the implicit association test, to uncover your unconscious associations, they found that doctors and non-physicians have the same level of implicit white race preference, which means an unconscious association of a white face with good things and a Black face with bad things. 7 out of 10. 7 out of 10 test takers who have taken that test have implicit white race preference. That is, they associate a white face with good things like family, joy, and love, and they associate a Black face with bad things like danger, violence, and fear. 7 out of 10 non-physicians and 7 out of 10 physicians who have taken that test. We had our admissions committee at my previous institution, the Ohio State University College of Medicine, take that Black-white race IAT. And here's the raw data from that project. 52% of the women and 64% of the men on the admissions committee, which by the way, is a very big committee, 140 people. We have 140 people on the admissions committee. 52% of the women and 64% of the men have implicit white race preference. Even more sobering, 10% of the women and 10% of the men have self-identified, described, admitted, if you will, explicit white race preference. There's a question that you're asked when you take the Black-white IAT, and it says, choose one. I prefer white people to Black people, or I'm neutral, I like whites and Blacks equally, or I prefer Black people to white people. 10% of our committee selected, I prefer white people to Black people. This is the group that gets to decide who gets to be a doctor and who does not. Here's our concern, that here's a young man who's interviewing for medical school. He's done all the right things. He certainly has done all the things that you would tell your mentee to do. He's got himself a nice new suit, firm handshake, smile, eye contact. Isn't that what you would tell your mentee to do on their interview day? But if that faculty interviewer, who is a fair person, I know they're fair people. I was the admissions dean. I know them. They're wonderful human beings, just like you and just like me. But if in their unconscious mind, when they look at him, they see a violent image, or they associate him unconsciously with a violent image, the question is, does that find its way into his evaluation of this young man? Does that find its way into how he evaluates his essay or his interview statements? That is the question that keeps us up at night as admissions deans. So we wrote this up, and what I've shared with you is what some consider the bad news, that a majority of our admissions committee had unconscious white race preference. And if that sounds like a lot to you, let me ask you, do you know what that number would be for your admissions committee at UCLA? If you haven't done this test, then you don't know, and you might be surprised. Do you know what that would look like for your residency selection committees, for your cardiology fellowship selection committees? If you haven't done this exercise, then you don't know. But while some people find that negative, there's a positive side, and that is that after we unveiled this data to our admissions committee and went immediately into an implicit bias mitigation workshop, the results were that the very next class we admitted was the most diverse class in the history of the Ohio State University College of Medicine. We immediately made annual implicit bias mitigation training a requirement for being on the admissions committee. And the medical school has continued to get more diverse, such that now it's one of the most diverse medical schools in the country, and it's been so for a number of years. So we've reviewed some data that both explicit racial bias and implicit racial bias can impair our ability to enhance diversity in medicine. What is the evidence that that lack of diversity harms our patients? Well, I'm going to get very cardiology centric here because we have a cardiology audience. But just know that as I talk about healthcare disparities here, we could be talking about cancer care, we could be talking about maternal fetal care, we could be talking about rheumatologic diseases, lung diseases, you name it. But we're a cardiology audience, so let's talk cardiology. In fact, let's go on rounds. So come on, let's go on rounds. Let's go to the hospital and let's see some patients. And here are two patients that we see. They're hospitalized with severe congestive heart failure and an ejection fraction less than 35%. As you know, one of the indications to receive an AICD is severe congestive heart failure with a poor ejection fraction that is refractory to medicines. So here are our patients and they fit the criteria. The question is, who gets the AICD? I'm hoping that in your mind, you're saying both, but that's not what the data shows. This study in 2003 looked at 6,000 Medicare patients who had survived a cardiac arrest. Now, you and I know that most cardiac arrest victims don't survive. If you're lucky enough to survive, there was a bystander that did CPR or there was an AED on site. If you're lucky enough to survive, then you're number one on our list of whom should get a defibrillator. This study examined such patients in a nationwide sample and found that the odds ratio for Black cardiac arrest survivors compared to white cardiac arrest survivors to receive a defibrillator was 0.5. Said differently, they were only half as likely as whites to receive a defibrillator after surviving a cardiac arrest. 2003 was a long time ago, I'll grant you that. 2016 wasn't so long ago. And in this study, over 21,000 patients in another national sample with severely weakened heart muscle and refractory CHF, they were deemed to be candidates for an AICD. The study showed that the Blacks and Hispanics were less likely than the whites to even be told, to even be counseled that there is something called a defibrillator that you should consider getting. And they were then less likely to receive a defibrillator. So let's move on to acute coronary syndrome, something else that talk about getting us up out of bed at night. This gets us up out of bed at night, working on acute coronary syndromes, and we love doing it. So we're making rounds. We're still on rounds, but now we're down to the emergency room. And we have two patients here having an acute coronary syndrome. And my question is, who gets timely cardiac intervention? Because we still know in interventional cardiology that an early invasive strategy for acute coronary syndromes, that is doing the heart cath and finding the blockage and opening it early as fast as you can, is superior to waiting around. We call that an early invasive strategy. So who gets timely cardiac intervention here? I hope in your mind you're saying both. Let's look at some data. Here is a study. This is an old one, but it's a goodie, 1999, actually used simulated scenarios. So they had actors. We call them standardized patients today. Actors play the role of patients who all read an identical script. You're looking at the actors right there. They all read an identical script that all said that, you know, feels like a ton of bricks sitting on my chest. I couldn't breathe. The pain radiated to my left arm. I had a drenching sweat. They were describing pain that a doctor would know sounds cardiac. And then they were asked, each doctor saw only one of these videos. They were asked several questions, one of which was, would you refer this patient for a cardiac catheterization procedure? The results showed that the white males were more likely than anybody else to be referred. The white females were second most likely. The black males were third most likely, and bringing up the rear, the least likely to be referred for a heart cath when presenting with acute coronary syndromes that were identical to everybody else were the black women. So in other words, when she complained of a ton of bricks sitting on her chest, taking away her breath, radiating to her left arm, she was much less likely to be referred for heart cath than when he said the exact same thing. I'm sure if you would have interviewed these doctors after this study, they would have said that they don't have any racial bias, that they are good people, and that they don't let race impact what they do, that they simply use their clinical judgment. Well, the only thing they had to go on here was history, and they all had an identical history. So what explains the difference? Now, I hear you that 1999 was a long time ago, but 2019 was not. And so in this study, we looked at an inpatient sample of over 4 million patients in the United States who presented with an acute coronary syndrome, either unstable angina or non-ST segment elevation acute MI. What we were looking to see is who gets their heart cath early, which we defined as within 24 hours of admission to the hospital, versus late, which we defined as more than 72 hours, 3 days after admission. So imagine that, if you will, for a minute, that you go to the emergency room with crushing chest discomfort and you're admitted to the hospital, and it's 3 days before you get a heart cath. What we found was independent predictors of late versus early coronary angiography were being a woman, being Black, being admitted on the weekend, and remember, these are independent of one another, so it's not that all the women and Blacks came in on the weekend, and not having insurance. So remember the previous slide that showed that Black women were least likely to be referred for coronary intervention when they present with acute coronary syndromes? That was 1999. This is 2019, and things are still the same. Because when we, in our study, looked at combining Black and woman, that group was least likely of all to be referred for early coronary angiography. Well, let's move on. We'll continue our rounds. We just saw the patient with acute coronary syndrome. Let's go now to the other side of the emergency room and see the patients with critical lower extremity ischemia. We got two people over there. With critical lower extremity ischemia, their foot is blue with gangrene. Who gets revascularization? Who gets a procedure that restores blood flow to the limbs? And who gets an amputation? That's a real question. And I'm hoping that your answer is why, of course, everyone who can get a revascularization should get a revascularization. The data shows differently. In 1995, this study of over 19,000 patients who had Medicare, who presented with critical lower extremity ischemia, showed that compared to whites, Blacks were more likely to have an amputation, less likely to have a procedure restoring blood flow to their legs. 1995 was a long time ago, but 2017 was not. And in this 2017 study, Blacks and Hispanics with critical lower extremity ischemia were more likely to get an amputation, while whites were more likely to have a procedure to restore blood flow to their limbs and preserve their limbs. What I like especially about the second study on this slide is that the second study controlled for extent and severity of disease at presentation. So even when they present with the same severity of disease, the same extent of disease, we still see whites more likely to get an angioplasty, a stent, a laser, an endarterectomy, a bypass, or something to restore blood flow to the legs. We still see Blacks and Hispanics having a limb amputation when they present with the same level of disease. We reviewed this topic in 2014, and what we found is that, and someone else had quoted this, but we included this in our paper, is that in an almost 20-year period, there had been 300 studies like the ones I just showed you, 300, showing the same thing, this disparity along racial lines in cardiovascular care. The sobering thing was that things were no different, as I've shown you, at the end of that 20-year period than they were at the beginning of that 20-year period. So after documenting the problem 300 times, things were just as bad. So somehow we've got to move from scholarly work that documents the problem to actually doing something about the problem. So this naggingly persistent disparity in cardiovascular care is parallel to a naggingly persistent lack of diversity in cardiology. According to the US Census, 51% of Americans are women, yet only 13% of cardiologists are women. 17% of Americans identify as Hispanic, yet only 5% of cardiologists are Hispanic. 13% of Americans identify as Black or African American, and not even 3% of cardiologists are Black or African American. Many believe, and you can count me in this number, that we won't make a dent in those racial healthcare disparities until we make a change in the lack of diversity in cardiology. So let's move on from how the lack of diversity can harm our patients, and we think is a major underlying culprit for healthcare disparities, to the opposite, how enhancing diversity just might improve the care of our patients. So I hope you've heard of Marsala Alsan's wonderful study published in 2018. She's from your state, published out of Oakland, California. And they did an interesting study in Oakland. They looked at the likelihood of Black men, Black male patients, to comply with a doctor's recommendation based on the race of the doctor. So they looked at interactions between Black male patients and either Black physicians, white physicians, or Asian physicians in a preventive care clinic. Here's how they did it. The Black patients were randomized to having either a Black, an Asian, or an Hispanic male doctor. When they arrived, those doctors said to them, here's what's available today: blood pressure measurement, BMI measurement, glucose measurement by finger stick, cholesterol measurement by finger stick, and a flu shot. And we recommend that you have all of those. Got it? Now, I'm going to show you the ultimate results of what happened, but I'm so glad that those researchers took this intermediate step. They analyzed the progress notes written by the doctors. So let me set that up for you again. The doctors are either Black males, white males, or Asian males. I might have said Hispanic before. It was Black, white, Asian. The patients were all Black males. They looked at the progress notes written. When you and I see a patient, we have to document something. We have to write a progress note. They saw a pattern with the notes written by the white and Asian physicians. The notes were short, really, really short and succinct and to the point. And here are some examples. Weight loss. That's it. That's the note. That's the progress note. TB test. That's an entire progress note. And here's a one-worder for you: anxiety. They also saw a pattern when they looked at the notes that the Black physicians wrote about their Black patients. And they noticed a pattern. The pattern was that the Black doctors' notes tend to take into account more the ecology of the patient, what's going on with the patient, how the social determinants of health impact the patient, and how the patient's frame of mind impacts the patient. Take a look at some of these examples. Needs food, shelter, clothing, and a job. Flu shot makes you sick, but he got one anyway. Subject yelled at me, but then agreed to get the flu shot because I recommended it. Made patient laugh. Do you feel a difference between those notes? It almost seems like you're witnessing a different level of listening and a different level of compassion. And maybe that's what translated into the ultimate findings, which is that those Black male patients were more likely to get a diabetes test by finger stick, a cholesterol test, and a flu shot if it was recommended by a Black as opposed to a white or Asian physician. On that same line, here's a study from Saha and colleagues published not too long ago, where again, they use actors, but this time not actors playing the role of patients, actors playing the role of doctors. And guess what? These actors played the role of cardiologists. So you see them there, and they're all reading an identical script. And that script says, essentially, I have reviewed your tests and you need open heart surgery. I recommend that you have open heart surgery. This time, the viewers of the videos were actual patients, actual heart patients, patients with heart disease. After viewing the videos, and each patient only saw one video, they asked questions, the researchers did, one of which was, well, will you have the open heart surgery? You heard what the doctor said. And the findings were that the Black patients were more likely to agree to open heart surgery if recommended by a Black versus a white physician. So that means, ladies and gentlemen, if you're keeping count, if we had more diversity in medicine, if we had more Black cardiologists, then more Black patients would have their blood sugar checked, would have their cholesterol checked, would get a flu shot, and would have open heart surgery when recommended. I don't know how much more strongly we can demonstrate that care will improve if we have more diversity in medicine. So why aren't we there? What are the barriers to enhancing diversity? Because this isn't a new notion. The AAMC, the AMA, the National Academy of Medicine, for years have been saying that we need more diversity in medicine. So what are some of the barriers? Because we need to understand the barriers so that we can get over those barriers and actually make progress finally. Well, let me tell you that some of the barrier is us. We are some of the problem. We don't all believe that diversity enhances quality. We don't all believe that diversity would be a good thing, or that diversity in medicine is something we should be working on. I know that's a pretty strong statement, but I'm going to show you some data to back that up. Here's a study published by the Society of Thoracic Surgeons. That is the organization, professional association of cardiothoracic surgeons, our colleagues. They have a diversity and inclusion committee who submitted a survey to the members of the STS. 481 people responded, 9% response rate. That's a pretty low response rate. But what they wanted to find out was, how do our members feel about this problem of a lack of diversity in cardiothoracic surgery? And to me, the real important findings were in the open question at the end. At the end, they said, tell us whatever you want to. What do you feel about this problem? I'm going to share some of those with you. One person said this: white males are currently being discriminated against in admission to college, med school, and residency programs. CT surgery should be a meritocracy. Someone else said, I do not believe barriers exist. This myth of the necessity of diversity and inclusion is political correctness on steroids. We need to worry about turning out well-trained residents. Somebody else said the STS doesn't need to address diversity, and this shouldn't even be on the radar of things to be done. And finally, somebody said there are no barriers. What are you talking about, barriers? There are no barriers, and none of the above are important. This is what I mean when I say that we are some of the barriers. Well, we also, you heard that I'm the chair of the American College of Cardiology's Diversity Committee. Before that committee was a committee and was still a task force, we decided to survey our gatekeepers. Gatekeepers to cardiology are cardiology fellowship program directors. We wanted to know how our program directors feel about diversity in cardiology, because we know that our specialty, as I've shown you, is not very diverse. So we sent out our survey. We got 110 respondents, which represented 57% of cardiology fellowship program directors in the US. You see there the breakdown between general and subspecialty. Here's one of the first questions we asked. Diversity is a driver of excellence in healthcare delivery. In other words, the more diversity represented amongst your providers, the better the care delivered to patients. Do you believe this? That was the question. Do you believe that diversity enhances quality? Well, almost 70% said yes. I suppose we should be grateful for that. 5% said no. 25% said maybe. So 30% of our program director respondents aren't sure if diversity enhances quality. The next question we asked was, if you think diversity enhances quality, cite your sources. Can you quote a study, 1 or 2 studies that support that statement? And 3 out of 4 respondents could not. So even though you and I know that there's a plethora of literature supporting that diversity enhances quality, 3 out of 4 of our program directors who responded to the survey were unable to quote 1 or 2 of those references. The next thing we wanted to know is what's on the mind of our program directors when they're making their rank list. So that's important to all of you because you ranked to match. That's why you are where you are. So what are our program directors thinking about when they're in that room and they're making their rank list? We gave 10 characteristics. We said rank them. Rank them according to which of these are in your top 3. The top vote getter, as you see, was clinical skills. No problems there. Number 2 was ability to fit in. Ability to fit in. And I wonder if that means the same thing to you as it does to me. And you can see the rest of them there. Next was research productivity, and then strength of the residency program directors later. On and on. Let your eyes go all the way down to the bottom. That's where you'll find diversity, or the ability to enhance the cultural competency of the fellowship program. So it is literally the last thing on the minds of cardiology fellowship program directors, at least the ones that responded to our survey. I'm still on this topic of we are some of the barrier to enhancing diversity. Now, if you've been anywhere on social media or on the internet in the last 6 months, you've probably seen a debate about this paper. This is a paper published in the Journal of the American Heart Association by a cardiology professor at the University of Pittsburgh. And despite its title, which might lead you to think it is a pro-diversity article, it actually was just the opposite. It was an article criticizing efforts to enhance diversity in medicine and in cardiology. Amongst the contentions in this paper, the author said, yes, it might be true that there are not very many Blacks and Hispanics in cardiology, but that's because they're not qualified, going off of their MCAT scores, et cetera. Another contention was, yes, it might be true that Black and Hispanic physicians of any specialty and in cardiology are more likely to serve the underserved, to practice in disadvantaged and vulnerable communities. But That's because they didn't pass their boards. And as you and I know, if you don't pass your board exams, then you don't have a choice. You have to practice in the ghetto because you can't get into privileges at the good hospitals on the good side of town. As you might imagine, this caused quite a stir. And it hurt a lot of people very deeply, particularly our trainees coming up through the system. So there was a backlash, and the Journal of the American Heart Association editorial board, after they received even more data that showed that there were some misstatements and falsehoods in this paper, they retracted it. They retracted the paper and said, we apologize. This doesn't represent how we feel about diversity in cardiology. I don't know how this got through. You know, our reviewers, our editors, they're busy. Somehow this slipped through the cracks, but this is not how we feel. Well, anybody who knows me knows that as soon as I was reading it, I was sharpening my pencil to write a rebuttal. We got together a group of authors to write a rebuttal. We did, we sent it in, and the first iteration, the editors said, Quinn, you got to calm down. You're too angry. You got to calm down, buddy. Your tone is not appropriate for an academic journal. So they bounced it back to us, and so we said, well, let's tone it down, and that's what we did. We toned it down, and we sent it back in, and they said the same thing. They said, Quinn, it's still too hot. You got to tone it down. So we finally did, and the third iteration they took, and so now we published this a couple of months ago, and now is a standalone article showing the need, and very evidence-based, the need for more diversity in cardiology. So you might have heard a little bit about that. You might have also heard a little bit about this, the recent JAMA podcast scandal. That was, JAMA had a podcast that they were sponsoring, and it was introduced by this tweet. It said, no physician is racist, so how can there be structural racism in healthcare? And in the podcast that was led by one of the associate editors of JAMA, the speaker was saying that because in the end of the 1960s, at the end of the civil rights movement, because discrimination and public accommodations were outlawed, there is no more systemic racism. How can there be? So we should stop using that term. This was actually said. As you can imagine, this caused quite a stir. And JAMA heard about it from a lot of people, and ultimately they retracted. And they issued an apology saying that this is not how we feel about structural racism in medicine. Yes, there is structural racism that accounts for healthcare differences. And we apologize. We don't know how this got through. Somehow this got through, but it's not how we feel. I'm willing to take the word of the Journal of the American Medical Association and the Journal of the American Heart Association if they say our editors and reviewers were too busy and forgive us, this just got by them. Okay, I'll believe you. But I'm concerned that there's another reality, that it's not that it got by anybody, but that some reviewers and some editors read it and said, it's about time. It's about time somebody said it. I've been wanting to say that for years. Accept it, and let's pass this on up the line. This all goes for my point that in our trek to enhance diversity, we have barriers, we have walls, we have hurdles that we have to get over. But some of the barrier is us. But we're not the only barrier. There are other culprits in our pipeline from kindergarten to medical school. We have significant leaks of talent all along that pipeline. We have a lack of visible role models, and structural racism, which is a thing, actually impairs people of color moving from kindergarten to medical school. Our gatekeepers, we have gatekeepers from kindergarten all the way to faculty search committees for the dean of the medical school. And our gatekeepers might have explicit and implicit biases, might be indifferent to recruiting, and place little importance on diversity when making their rank list. I've shown you some data. And then finally, the culture in academic medicine is steeped with inertia and unconscious bias. So those are the barriers. Let's end now on a positive note. How can we get over those barriers? What are some things that we can all be doing? We can all reach back, and I mean way back. into the deep pipeline. I'm talking high school and pre-high school. We can mentor relentlessly everybody that comes in our purview. Be visible. When you talk to people who at one time wanted to be a doctor and then they gave up on that dream, one of the most important things they say is, I didn't see anybody that I can relate to. I didn't see anybody that looks like me. So we can go out of our ways to be visible. And that just means you and I can't be everywhere. That's where social media comes into play. You can extend your influence on the internet and be a social media. Encourage your mentees to go into academic medicine, confront bias courageously, engage the gatekeepers. Don't mean to throw them under the bus. They are us and we are them. We are the gatekeepers, but we need to support them and we need to help them to do what they need to do to stand strong when they try to enhance diversity. And what if we made diversity, or the ability to enhance the cultural competency of the program, whether it's medical school, your residency program, your cardiology fellowship program, what if we made that a top 3 priority when making our rank list, so to speak? And when you do these things, don't do it and be a local hero on your own. Write about it so that others can learn about what you're doing and reproduce your success. I'm going to end now with some photos showing some things that we can all do. I'm sure this is the cutest slide you'll see all day. These are kindergartners in the K through 12 Health Sciences Academy, a joint venture by Ohio State University and Columbus City Schools. These youngsters are having the health sciences in their curriculum. If you can imagine a kindergarten curriculum that's introducing the health sciences, that's what they're getting. And they're going to get it all the way through the 12th grade. And of course, what we're hoping is that in a few years, we're going to see some applications to medical school out of this group and some applications to cardiology fellowships. So these are things that we can all be doing. Now, this is a really big deal, but it doesn't have to be this big. We can all interact with young people. Here's an example. At The Ohio State, we used to hold on Saturday what we called Heart School, where 4th graders would dissect hearts, proctored by our medical students. And keep your eye on that young man right there. That's him as a 4th grader. That's him as a pre-med student at Northwestern. And that's him as a medical student in my clinic, at one of my last clinics at The Ohio State University. So we mentored this young man from 4th grade to medical school. So I'm not sure how many more 4th grade to medical school cycles I have left in me before I retire. But how about you? How many times have you sat down? When was the last time you sat down with a 3rd grader or 4th grader and said, you can be a doctor. I believe in you. You can be a good doctor. You can change somebody's life. Mentoring. We know that Black males are, in a very short period of time, going to be at a crisis level shortage in medicine. So a Black male mentoring roundtable where we get our attending physicians and students together quarterly for dinner, for advising, for socializing, and to inspire these young men is something we started at Ohio State 7 years ago. This picture was taken pre-pandemic, but no big deal. Come the pandemic, we just moved to Zoom. And now the Black Male Mentoring Roundtable has come to Dallas, Texas. And we've had 2 of these already, and people find this really inspiring and helpful. Using social media. We started this hashtag Black Men in Medicine to inspire youngsters. What we do on Twitter is put out a tweet under this hashtag Black Men in Medicine to inspire. So today I want you to take a selfie and say something inspiring and use that hashtag Black Men in Medicine and post it on Twitter. People are watching. Within our first week of this hashtag, there were 17 million impressions, people interacting with the tweet. So do this so that we can encourage young people to go into medicine. Confront implicit bias. We wrote this paper to be a how-to on how to operationalize bias mitigation. One of those things is to actually have an implicit bias mitigation cheat sheet. This is interview day at OSU's medical school. The interviewer has in front of him not only the credentials of who he's about to interview, but a cheat sheet of implicit bias reduction strategies. And this is us doing an implicit bias reduction workshop with the ACC Board of Trustees. We've wrote this paper to propose a new teaching tool, bias and racism teaching rounds, where just like M&M rounds, we get the care team together quarterly to review racially insensitive remarks made about or to patients evidence where we think racism has impacted our decision-making. We discuss them in a teaching manner, not to embarrass anybody, but to help us learn so that in the next quarter, we will have fewer incidents. And what if we were to make the ability to enhance diversity or cultural competency a top priority when we make our rank list? At The Ohio State University's Interventional Cardiology Fellowship, we have been doing that for at least 5 years. This is the interview sheet that we use when we're interviewing candidates. If there's anyone on this call that's going to apply to interventional cardiology at Ohio State, you should know that you will be rated on whether or not your letters of recommendation cite your cultural competence as a trait, whether or not you've participated in community outreach activities, whether or not you've been exposed to cultures other than your own, and exposed to taking care of patients from disadvantaged communities. When we use this as a tool, it contributes to this. Every year, for the last 8 years, at least one of our interventional cardiology fellows was an underrepresented minority. This is what it looks like when you truly believe that diversity enhances quality. In conclusion, the lack of diversity is due in part to racial bias and racism. This lack of diversity is killing our patients. And enhancing diversity is not going to happen by accident. It's got to be intentional, but that intentionality is fueled by belief. So that enhancement must be intentional. And of all of the anti-racism statements, let me just say, this is the anti-racism statement that we want to see. Thank you very much. That's all I've got. I know we only have a few minutes left, but I'm happy to entertain any questions, comments, or anything anybody wants to talk about.
So I'm Shelley Shapiro. I'm one of the cardiologists.
Hi.
The Philharmonic, when they audition people, they put them behind screens so you can't tell whether they're male or female, black or green or whatever. And I know it would be tricky to try to do for medical school interviews and cardiology fellowships, but it might be possible to de-identify people in a way so that we more objectively just look at their criteria, and even in an interview, get information without and try to sort of sort out the bias that way. I don't know if that's feasible, but it seems to work in the Philharmonic with more women and minorities being in the orchestra instead of all men.
Yes, yes. So thank you. Thank you for that comment. And you know, I think we're moving to a place where best practices in selection for medical school and residency does include some de-identifying. At The Ohio State University, a while ago, we got rid of the photos because we used to have, when we would sit around and deliberate and vote on our medical school applicants, we used to have the application with their photo on it. But it became clear to us that was feeding into our biases. So we took the photos off. You can do the same thing with ERAS applications for residency and fellowship.
I'd like to ask a question. Let me start by really just congratulating you for your leadership nationally and internationally in this area. I mean, your visibility, I think, is going to have multiplier effect impacts, and I thank you for really taking up the mantle. My question or comment relates to allyship. And, you know, in the list of recommendations that you made to sort of mitigate, you know, sort of the barriers against diversity, I think there's a lot of onus that's put on the few of us underrepresented minority physicians. And so I wondered if you could comment a bit on allyship and sort of this idea that diversity is actually everybody's responsibility. If you're a physician and you care about patients not dying, even if you're not a person of color, it's your responsibility to enhance diversity and things that would help patients survive. So if you could comment on allyship and sort of where you see that, I think that would be great.
Thank you. Thank you so much for first for your kind words and also for an incredibly important comment. So you're absolutely right. If you look back at my list of action items, they're agnostic to the identity of the person doing the work. And what I usually like to say is, when I was a fourth grader and dreaming of being a doctor, but I didn't see many doctors in my neighborhood or in my community. If a doctor of any race or any gender would have sat down with me and said, Quinn, I think you can be a doctor, it would have been inspiring to me. So I wouldn't have cared if it was a white person, if it was a woman, if it was an Asian person, if it were Hispanic. It would not have mattered to me that they didn't happen to be a Black male. And so this is work that we all can do. We can all work to dismantle racism, to dismantle bias, to mentor, to sponsor people chasing the fact that, as you said, it will save more lives if we have more diversity in medicine. So we critically need that. I mean, you're right. Those of us, the few of us in medicine now, are only about 6% of physicians are African American. Only 6 or 7% of physicians are Hispanic. If it's us by ourselves, our backs are going to break with the weight of that. So we're only going to make progress if we have everybody pulling in the same direction. So thanks for that really insightful comment. Well, it looks like we got 60 seconds left. I wish I was there in sunny. I don't know if it's sunny there or not. It's not a bad day here in Dallas, Texas, but I wish I was there with you. Thanks so much for the invitation. You're in a great program, and I'll look forward to seeing you all at the heart meetings. Thank you.
Thank you. Thank you so much.
Dr. Capers. Thank you.
Thank you.